Good morning, everybody. My name is Carlo Nimle, and it is my pleasure to serve as your moderator for this session. Thank you so much for joining us. In 2018, the World Health Organization modified its commitment to primary health care as documented in the Alma Ata Declaration of 1978, now known as the Declaration of Astana. Article 3, paragraph 3 of that declaration states, and I quote, "Promotive, preventative, curative, rehabilitative services, and palliative care must be accessible to all. We must save millions of people from poverty, but particularly extreme poverty caused by disproportional out-of-pocket spending on health. We can no longer minimize the crucial importance of health promotion and disease prevention, not tolerate fragmented, unsafe, or poor quality of care. We must address the shortage of uneven distribution of health workers. We must act on the growing cost of healthcare and medicines and vaccines. We cannot afford waste in healthcare spending due to insufficiency," end quote. While the WHO reaffirmed its commitment to primary healthcare, it realized that primary healthcare alone is not enough. There must be a collaboration between primary healthcare and public healthcare to meet population health needs effectively and successfully. Health disparities and health inequities are global phenomena, but our solutions must be unique and specific to our community. To find the right solutions for our community requires our commitment to collaborate with our communities and the willingness to listen to what the community is telling us. We have challenges, yes, but we are not defined by these challenges. Rather, we must see them as opportunities to act. We can no longer wait for someone to act. It is upon all of us to act in identifying and addressing health inequities in our towns, communities, cities, states, and the world. We have gathered the last 2 days and heard from health experts on the various areas of health disparities and injustices in various communities and what is being done to address them. Let's not just hear these presentations to go back to the status quo. Take action to make a change today. Establish a new normal in your community. Play a new song today. Are you ready to make a difference? We will begin the session with our panelists introducing themselves and their organizations. Each panelist will have 10 minutes. After the introduction, we will then engage in discussion. Thank you again for being here with us, and we look forward to a greater health access. Thank you. All right. So we have our 5 panelists on. We are so happy and grateful that you have agreed to join us today. Please go ahead and introduce yourself and the organization that you work for.
It looks like Alina's having some difficulty, so I'm going to start us.
That's
great. Hello, everyone. Good morning. My name is Dr. Claudine Richardson. I hope you're all doing well out there since I can't see you. And so I serve at the Washington Department of Health as the Environmental Health Disparities Map Equity and Social Justice Strategist in the Office of Environmental and Public Health Sciences. And yes, that is a mouthful. And so I come here today at the pleasure of kind of sharing experiences and coalition building. My pronouns are they, them, theirs, and I'm also representing my Arawak tribe, which is a small tribe in the Caribbean, if you've ever been to Aruba, Borneo, Curaçao.
Thank you, Claudine. Eachikuk ekmastukin Clarkin Renaimo manes when excellent questiones by Yachayak Waunasipa. My name is Johnny Buck, and I'm a founding board member of the BIPOC Health Careers Ecosystem that we refer to as the ecosystem. I'm also a second-year master's student at the University of Washington in Human-Centered Design and Engineering, and currently UX designer with the Tubman Center for Health and Freedom. and I prefer he, him pronouns.
Hi, my name is Alina Swart. I'm in Clarkson, Washington, which is the native lands of the Nimi Poo or Nez Perce tribe. I am a member of the Health Equity Zone Initiative Community Advisory Council, along with a few others, to name a few, Poverty Reduction Work Group Steering Committee and Parent Ambassador Alumni. And my day-to-day, I am just a mom who cares about early learning, health, and economic justice. I like to be a solutions gal. I see a problem and try to come up with ways to fix it. Sometimes that means seeing what needs fixed and going backwards. I don't just want to recognize a problem. I want to see solutions that won't have a negative impact. What I try to bring from my experience is seeing where all the deficits are. I've battled the problems and know what would make it better for me. I have a PhD in poverty and speak it fluently. I know what it means to struggle, be homeless with children, and I've seen the struggles and fought the wars of trying to get adequate care.
Good morning, everyone. My name is Jan Marie Ward, and I'm glad to be here with you today. And thank you for the organizers for inviting us all to join them in this important session. I am a lineal descendant of Santa Ynez and Barbareño, California Mission Indians, and have lived in the Pacific Northwest for 46 years. Much of that time, I've worked with the tribes and communities across the state in various different capacities. Today, I'm here representing the Washington State Public Health Association. I'm the immediate past president, meaning that I served in the last term, and I continue to be on the executive board and chair the DEI committee for that organization. I also serve as the senior public health policy and project advisor to the American Indian Health Commission as a consultant, and have done so for about 13 years. Prior to that, I have been involved in work that has been centered around addressing issues of poverty, social justice, and discrimination and racism for many years. I'm glad to be here with you today and look forward to sharing more. Thank you.
Good morning, everybody. My name is Mustafa Muhammad. I'm a refugee from Iraq. I came to America in 2008, and I'm represented the refugees, asylum seeker, and immigrants, and advocate for BIPOC communities and people in color and minority people, elders, and teens. I'm president and co-founder of the Human Rights Protection and Gold Peace Agency, and a mental health professional and clinician supervisor, and a board member in health and mental health in King County. Also, I'm a member of the Health Equity Zone Initiative Community Advisory Councils. I wear many hats, so day to day, I'm busy like 24/7 because also I'm a physician and an MD, so I have patients overseas, so my phone is keep ringing till 3 a.m. every day. So this is my job. And the role of the board, that is I role in the Community Advisory Council because of compassion and advocate for other people, and bring my experiences as a refugees that came to the state and to see what is the obstacles that have the health system here. And I'm happy that I join you and having me. Thank you so much. And also, I forget, I'm also executive member, specialist of the Musketeer Association in Ohio, a specialist for the Midwest and Africa. Thank you so much.
Well, thank you so much to all of our panelists. You bring a huge background experiences that we could all learn from you. So to start the discussion today, I want us to focus on this question. What do we need to do differently to achieve health justice and belonging in the 21st century and beyond. Claudine, do you want to start us with that?
Or I'll bravely try to provide something. So I think when we think about that question, I think we have to talk about some of the notions that we have that came out of the pandemic that I think need to be peeled back. So during the pandemic, many of our state agencies and local governments recognized that people were disproportionately impacted due to the viral pandemic. And one of the misnomers of that is that they were disproportionately impacted due to the pandemic. We had been disproportionately impacted for generations. And so the pandemic, the viral pandemic, just shed a major light on that. And so with that said, a lot of our grassroots efforts that had historically gone unknown or covered up or failed to be funded appropriately came forward together to say, you know, what you're doing is not only not enough, what you're doing is actually harmful in some instances. And we decided to pick up roles that we oftentimes do because we are at the extreme ends of deciding, like, you know, what are our options to take care of our neighbors and our families and our children to make sure that we, you know, have the basic necessities of food, shelter, you know, simply to survive. And so I think when we talk about conversations about what is like the new normal look like, I think you need to think about all the innovations and who has often been the mother of those innovations, and that is those who are the most minoritized, impacted, and invisibilized in terms of community members. And so when we think about this new normal and we think about what does health access mean, we have to think about, like, what are the threats to this health access? What are also the environmental health threats and the social health threats that are impacting us as well? And we need to be mindful of how we build spaces to address those concerns. I used to work in post-secondary education at the community college level. Hello, community colleges of Spokane, particularly Spokane Falls, as well as some four-year public and privates. And one of the things that I thought that was really important is that if you're going to make a decision about students for students, you should have students at the table. Same thing when it comes to Washington citizens. If you're going to make decisions about those who are at the margins, you need to make sure that not only do you invite us to the table, but you listen to us. And more importantly, that you make sure that that's 2% of that population has the ability to build the table. And not just when you are drafting something, but before the draft begins, to help you understand that, you know, we need just transition and we need to be able to do it as a group of persons who are impacted, right? And so one of the things I really appreciate on my current role is that we are recognizing that historically we did a misstep, and the Washington Department of Health is going through our anti-racism and decolonization restructuring and lens for the last couple of years, and it started before the pandemic, to make sure that not only are we trying to involve community members, but we are trying to practice how we want to show up, recognizing that that's who we become. And so we are going through professional development, and we are making sure that we are practicing doing community engagement, where community members are not coming and feeling tired for trying to tell us the same thing over and over again, but also making sure that we listen to what they have said to us. So when we show up to their spaces, we're not trying to change the conversation, but we're trying to make sure we're doing our due diligence to listen to them deeply and asking them, okay, is this what we heard? Is this what makes sense? And even when we collect data, that we go back to those communities and say, is this what you meant? And so that's what I think about in terms of that question.
I would just add that thank you so much. I think you really encapsulated many of the issues that we are, certainly dealing with right now. But what I would just emphasize really is around centering around the concept of those that have the lived experience have a different level of knowledge about what the history is, the context of the experience, and really are the only ones that can come up with really that deep understanding of what the potential solutions are. And I think that when, we have certainly education and people that study the field of public health and social health, and come with that the traditional educational knowledge, and that is wonderful. But we have to have those people that have the true knowledge of knowing and understanding of those experience to put those things on the table in a way that we can dive more deeply into the root causes of issues that we will never get to without their voices, our voices. So I just want to emphasize that, because I think that many even scholars, specific scholars from Indian country have talked about this in different ways, and philosophers, political thinkers have thought about how and have written about that those that have that lived experience really need to be the guideposts of those solutions. And I think that's really important. Also, one of the things that I like to emphasize too, from the perspective of Indigenous thinking, and it may relate to others as well, is culture is so important and an integral part of our health. And that cannot be left out in the conversation about how we go about thinking about achieving that whole health and wellness, so we all can thrive. And what that really means, and how values are centered around culture, that we will never get to unless we include that cultural piece. An example is how important language is in our Indigenous languages, and we see that movement that is so much part of our early learning settings right now. And we've seen the difference that really makes in starting our kids off in a very strong way, very rooted in their own language. That's an important part of their culture.
I just also want to add, and I emphasize by two of my the panelists also that, and I agree with them, the culture and the language they speak, because what I saw through my to live experiences, like you should listen to the person, to the patient, to the client, and see what they need before you treat them like a robot. At the end of the day, they are a human being. All of us we came from Adam and Eve, and there is no difference in color from where they are people they came. So we just want to listen to them and see their need, meet with the leaders and see what's they wanted, and then read these and make a data and remove the obstacles in the health system. That is, they failed us since long time ago. And also, through the, as Jane said, you should bring the lived experience, the lead of that, because they live that. They know what they need. So the people that is hierarchy in the Department of Health, on the health system, listen to them and can put this plan to solve it in order to serve our community. And that's why the health equity zone that established. This is because of that. It's so important. Thank you for listening.
Just to add on to, I think when thinking about like systems change, and say we go to a hospital, right? And we're probably not going to see somebody that is like from our like BIPOC communities, right? We're probably going to see a white doctor, and it's not going to feel safe and like all of these things, and or welcoming at that, and we're afraid to go. And I think that when we think about, say, our community members that are looking to go into healthcare careers, it's really difficult, right? We get so far, and then we say, oh my gosh, like we haven't increased the number of medical doctors from our communities for decades, right? And the system is failing us. The system is failing us. That's what the notion was. But actually, when we rethink it, the system is actually doing exactly what it was designed to do. And when we look at the programs too within these institutions that support healthcare careers, it's very competitive, right? So there is this divisiveness also in terms of like not collaborating, especially if there's alignment. So I think like the new normal is really breaking these barriers and silos down, and beginning to collaborate and work with each other, because we have the same mission, we have the same vision and the goals to support our community. So I think, just adding on to what others were talking about, addressing the social determinants of health, the culturally competent care, where healthcare providers should receive training in cultural competence to better understand the unique needs, beliefs, and values of our BIPOC communities. And, this includes the language access services, respecting cultural traditions, and incorporating culturally appropriate care practices. And, even with the data collection and monitoring, collecting disaggregated data on health outcomes by race, ethnicity, and other relevant demographic factors or metrics that we decide are important for us to identify disparities and track progress over time. And this is that data, that evidence base that can really lead to inform policy decisions, allocate resources effectively. And I think there's a huge aspect that the values of self-determination or sovereignty within our communities that need to be exercised.
Oh,
I'm going to add something to that, because I think Johnny was, giving hot fire out there to the audience. And so I don't know if I can add anything to that hot fire, but I'm going to attempt it, right? And so I think when we think about, our communities, and along with what Jan Marie shared, like those who have the lived experiences, that is something historically that our systems do not want to consider when we think about who we bring into spaces, right? And so I would just go ahead and underline that and score it, because we have the historical nature in terms of organizations, agencies, or state agencies to want to bring people in for their lived experience, but not compensate them accordingly for that lived experience and use it as an add-on. And so when we think about how do we go ahead and create systematic changes, I would say rather than just, looking on there and having conversations with me about how we're going to do this, I would say, well, first of all, do you have persons within your agency right now that are silent because they are noticing that what you say versus what you live are not correlated or parallel or in synergy with each other? And as persons who are minoritized, when we think about the health and well-being of ourselves, we have to think of that not just mentally, but also in terms of our economic feasibility. And as a result of that, we've emotionally pulled back for our own well-being. And so I often say to people, what has been your account of yourself, right? In terms of your values, what has been that axiology that moves into your method of how you orient yourself to the world? And how is that showing up in your workspaces when you come together to create that norm, right? I always call it, a contract, like we're developing a contract. When you hire in halo bias persons who have similarities to you, whether that be phenotypically or culturally, you're creating a homogeneous space. And that lack of homogeneous space during the pandemic of all times, we saw companies dissipate and disappear because there was very little innovation happening in those spaces. But also what we create as that homogeneous space becomes our norms and procedures, and how we turn it into policies, right? We've normed it so much that anytime we see something different, Daryl Wingsu calls it the dot on the white piece of paper, that immediately we're like, oh, this is wrong. And usually it's those who are at the extreme ends of the margins with that lived experience who are calling in like, there are other ways of knowing. There are historical, cultural heritage that we need to acknowledge in the space and reconcile if we truly want to help others. And that should be our new normal, not what you were accustomed of doing in the past. I think too, one person asked me during a professional development last week, they said, and I'm like, the absence of something, y'all, is the something. And so when you talk to me and others who represent some of these communities and have these lived experiences, we hear the absence of something is the something. So one person said to me, are there any qualifications beyond race, gender, identity, and religion, accessibility that we should be considering? And I'm like, at no point from our communities that I know of did we say seek people who are unqualified, right? And so I'm like, that is a misnomer that tells me about you and how you think who is deserving of what access. And that access turns into healthcare. One of the things that people know is people know about microaggressions, but they don't know about MEES, mundane extreme environmental stress, that happens to persons either who are in the healthcare system as employees or persons who are receiving that care. And in that same alignment is what our students are experiencing in post-secondary education and secondary education, right? And so when someone says, we don't have qualified people in these realms to support creating this new normal where multiple voices and those at the extreme ends who have been ostracized and negatively impacted mostly by these decisions are not there, I'm asking them, what pipeline did you create at the college level, at the community college level, at the high school level, at the middle school level, at the elementary level, right? And so, I think that's extremely important. And I'm going to say something a little bit controversial here, like phenotype does not equal your mental time, right? And so oftentimes in situations, and I'll account for myself, I am obviously Black. I am Panamanian Dominican. I am Arawak from my tribe in the Caribbean. I am part of also the Madrashtra because I'm East Indian. I'm Japanese, Chinese. But when y'all look at me going down the highway at 70 miles per hour, you see Black. And that's why I claim it first, right? But if you do not, and I'm Dutch. And so if you do not have a historical context of what it means to have these experiences in the US, sometimes you can get conflated experiences of persons saying who is deserving of what, because you're picking what you're comfortable with in terms of a historical culture and context, rather than picking what needs to be done and said. And so when I think about how we move to the new normal and how we value care and belonging that we know has an impact on health, right? Then I think about, how are you normatizing those spaces and how are you putting your money where your mouth is to be truly accountable and create an infrastructure?
I just want to add to that. Thank you so much, Claudine, for your articulation on and touching upon so many topics. I think that what I want to just break down a little bit is the concept around, again, the voices of those with lived experience and how they may have a different set of values than is what is considered the norm. And I know, not all too long ago, and I would even say pre-pandemic, that wasn't long ago, but, the floodgates have been opened up here because of our experience together during the pandemic. where the population has had this collective experience about ongoing trauma. It really has opened the doors for people to have that experience and think about how it's impacting others. We had been talking about historical trauma for years, and in certain settings, it would be raised and the conversation would go on, not acknowledging historical trauma at all, until there was a sense of some experience that the broader collective had, that they could, identify it, associate, have some connection or emotional association to it. I really believe that's true. I think that one of the things that that happens as we're doing this work, that is more bringing around that concept of engagement, community engagement in a broader sense, more than just stakeholder management, for example, that it can't just be a one and done. I mean, as you talked about building the pipelines, also that we're not just having one listening session, that we're bringing people in a real way, so that they are ongoing avenues for being part of those processes to identify solutions. Because what people hear sometimes, again, they put it into their own lived experience and take it down the road without those people that actually have a sense of what it is to have the intersection of many different things that you have all talked about. So we have to be present. We have to be present. We have to be part of the systems. We have to be educated and be educators in those systems that are creating the structures that are making policies and are in front of that systems change.
And so let's hear from Ms. Alana. She hasn't spoken yet since she introduced herself. And then I do understand that Dr. Mustafa and Alana has presentations, right? So once Alana provide her input, then we will go to Dr. Mustafa for his presentation, then we'll go to Alana, and then the discussion will continue.
Mustafa and my presentation is together, so that will make things easier. I just don't think we can say enough. Listen to the patients, listen to the people. They're going to tell you what they need, and they're not usually going to tell you the wrong thing. So I mean, that I really didn't have a ton to add because everybody said everything so eloquently, but definitely can't say enough to listen. Just listen.
I just want to add something, like I emphasized that James and Claudine said, and also that Alina, that the COVID should taught us a lot of things, that the system failed us. And we see, like we are in developed country like USA, but the system failed us. There is many people die because of the system. And because of the provider one, they don't listen to the patient. That's why we have, this is a lot of death. Because if they listen, we can prevent these deaths if they know about their client and patient history. And we, as Jane said, that is, we talk about a lot of times of historical trauma, but we don't go to the deep, how does it affect the person mentally, that they cannot function. And that is especially the BIPOC communities. And I have a lot of stories with that, with my patient, with my client, even with my friends. That's happened during COVID. And every day I hear not one story, maybe 10 times, sorry, that is the system. The insurance company failed the patient. They treat them like a shit, sorry to say that, but it's like the animals. If you don't have the money, you cannot have the insurance for the medical health. And especially the refugees, the BIPOC, the immigrants, these things that is, we should advocate from them, and we should put a plan and solve these and remove this obstacle in the system. Thank you. So here is our slide, me and Alina. I'm gonna go first. As I said, my day-to-day work is like busy 24/7 because I'm a compassion person. I advocate for people before of myself, and even advocate for myself because I came as a refugees here this 2008. I fled because of the war from Iraq. And I left everything there. I lost everything. So I came here as a broken person, nothing. And when I came to here, the system said, oh, you're nothing. So there's a microaggression, there is even aggression, the discrimination, racism, anti-Islamic, all these things I faced in 2008. Even I was depressed and have PTSD because of the war. Because I was kidnapped, I was having car bomb, so I should build myself again and again. And what I bring to this and live experiences like knowledge, experiences of this 30 years that I graduated from medical school when I was 23 years old, and to bring it to the system, and we can put the plan, and then we remove these obstacles. So that is me. And if you want Alina to introduce yourself, and that's me on the left side.
I already introduced myself.
So we can go to the
I'm
other,
good.
yes. So what by the end of this presentation, we want to know the basic about Health Equity Zone Initiative in Washington and how it is is innovative, and our experiences in Community Advisory Council, and what we recommend for including and centering community voices. And we hope to answer questions from our individual presentation. Next slide, please. Alina.
The history of the health equity zones is that the Rhode Island launched the Health Equity Zone Initiative in 2015, building on earlier work in low-income communities. Health equity zones are a strategy for addressing health equity that is encouraged by national organizations. Cities are also using this approach, such as Healthy Chicago Equity Zones. In Washington, State Senate Bill 5052 was introduced and passed, tasking the Washington State Department of Health with implementing the initiative. The Department of Health convened the Community Advisory Council with representatives from across the state from diverse communities. The CAC led decision-making and shaped the process of zone nomination and selection. CAC members added the structure of 3 zones: 1 rural, 1 urban, and 1 zone for Native communities. A total of 43 complete nominations for urban and rural zones were received from across 21 counties in Washington. The CAC reviewed these nominations, came together and deliberated, and in June 2023, the first 2 zones were selected for the pilot phase of the initiative. An evaluation committee was convened that includes CAC members and other community and has delved into the data collected for reflection and improvement of the process. An in-person led by the evaluation committee will take place in March. The Community Advisory Council's tribal community representatives and a review panel of Native individuals have convened to design the selection process for the zone for Native communities, which will open on February 28th, 2024. The form will be open until May 22nd, 2024, with a selection in summer of 2024. Mustafa, you're muted.
Thank you, Lena. And this slide, in recognition of the deep and long-standing inequities in community across Washington state, lawmakers passed Senate Bill 5052 in 2021 to create the Healthy Equity Zone initiative. This was in response to the growing understanding of how the social determinants of the health can impact communities that are geographically connected. The Health Equity Zone initiative is designed to support communities in coming together and identify their priority health needs and determine and support community-based strategies to address them. This model recognizes that people living in the community with significant health barriers often have the best solution to improve the health of their community. This next slide, you can see that's gathering last year in the CTAC. And so you see me on the left side with the orange. All of us, remember, we can make it in this meetings. The first, we became involved in November 2021, as we said, and it has been a huge commitment. But there are 20 additional extraordinary individuals of all different backgrounds and experiences. We work as a one team and we have brainstorm, and there is no hierarchy between us because we are human beings. The process of being part of this group has not always been easy. Personally, I had faced death and illnesses of my close friend, lover, my mom, and you can see me in the orange. I lost hair 30 pounds and I was so depressed, but I pushed myself because I'm compassionate, want to help people and bring their, so I went there with my colleagues and they support me for the DOH. And the other, also each CAC member have also their story and they struggling, but they made it because they love their job. They love people and what to do. But knowing that all the CAC members are hanging in there during this COVID and post-COVID, their own difficulty kept me going. We are supported by staff at the Department of Health who have worked through many challenges with us. Increasing opportunity for, and what I want to bring, it is increased opportunity for everyone to live the healthiest life possible, no matter who they are, where they live, and how much money they make. In addition, I hope to help expand and serve and provide health equity for a wide variety of people in community to address obstacles of the health, such as poverty, racism, discrimination, including anti-Islamic sentiment that pervade in the American system and their consequences, including powerlessness, lack of access to the good job with fair pay, quality education, and housing safe environment. And also hope to better study these barriers and help to plan and implement education for all involved in order to better fill their needs.
Hi, Alina again. That's me in the burgundy on the right. I first became involved in the process of forming the CAC in November of 2021. To get to the pictured meeting in June of 2023 from Clarkston, Washington, it took 9 hours and 2 rental cars. Over the course of our 2-day meeting, my husband watched our 2-year-old in our room as he does not do very well without being away from me. He's 3 now, but still not a fan of being away from mom. While I had a sitter watching the rest of our children at home. It really felt nice to feel invited to the table and not just to check a box, but acknowledging lived experience. And that makes me an effort or an expert in the health and whatnot of the community. It's been really nice to not have my experiences and ideas dismissed. Also, it gives me a sense of pride. One of my major contributions was that we selected 3 zones to make sure it was as fair as possible. Not only did I suggest that, but it was enthusiastically received. Overall, it is really fulfilling to be able to see a community have something available that they did not have before with those first two zones.
Here's the other slide, that geographic representation of CAC member. It's map of Washington that showed the counties for the AC member came from the bride. So we are gathering from Austin, Spokane, Walla Walla, Yakima, west of Cascade. It is like Clark, King County, Gray Harbor, Snohomish, Thurston, and Whatcom. And the council currently has total 15 members who are tribal partners, community representative, and sector representative.
Here's a map that shows the location of the first two zones that were selected. The CAC deliberated for 2 days to select from the top nominations. We wish we had been able to select one Eastern Washington and one Western Washington community, but with the funding for only one urban and one rural zone, we were limited in choices. The CAC agrees that more funding would allow for geographical representation.
So the core strategy of evaluation are convening of evaluation team that include those impact. The evaluation team is one of the DOH epidemiologists and 6 community members with varying level of experiences. The team uses reflective dialogue, share ownership of finding, collective analysis data, and which was done manually. The result is increased skills of team member and great agreement on the interpretations of finding.
This diagram shows how power was intentionally shifted from the Department of Health to a model where community members exercise decision-making power. Community leadership is crucial in providing feedback on structure and process to make sure participation is inclusive and communicating about needs and challenges. Together, CAC members and DOH staff commit to values of transparency, putting community needs at the center and building a collaborative relationship rather than power structures that place government in the lead role.
On this slide, that's Alina and I reflect in our experiences, and here are some of our recommendations for partnering with community members for long-term involvement and decision-making. So be aware of the needs of community members, including the time, commitment, and shifting timeline if needed. Compensate community members for their time. Many people did not have even ability to donate their time the way that some professionals can. Truly respect the value of the lived experience of community members, and they have often survived greater adversity than you can imagine. And communicate regularly, account for language access, and follow through on sharing decision-making.
Here are some policy recommendations from the CAC. Part of what has made this process hard is how limited the funding is. When there were so many fantastic and promising nominations, it was nearly impossible to choose just 2. What you pay for is what you value. Our state would see better health for all if funding was allocated appropriately. When you are building programs or initiatives, build community members and decision-making in. This means taking time into account financial constraints, needs such as transportation and childcare, and honoring cultural norms. When you identify experts, consider those of us who have been directly impacted by policies as experts on our lives. Pay us for what you would other experts. Most of us have a PhD in poverty. Make sure patients have what and who they need to create safety and trust. This might be a community health worker, a health professional who speaks the same language, people who don't have unfair expectations. Make sure you have enough help for you and your patients or clients, and don't be afraid to ask for it.
So here's the information on how to contact with the Health Equity Zone Initiative. And there is page on Department of Health website that can provide more information. And you can scan the QR code to sign up for the Health Equity Zone newsletter. And you can also email the DOH Health Equity Zone staff at healthequityzone@doh.com, .wa.gov. And I just want to emphasize, sorry for my language, maybe I make maybe a mistakes for call the BIPOC community because my friend in Roqeya, the Musketeer Association in Ohio, that is we started to not use BIPOC. We say Black, brown, indigenous. So I need to change that and also the system because they don't like to call that in the system. So sorry for my language and I apologize for that. I just want to correct that. So I call BBI now. We use that. Thank you for listening.
Am I going live now? Well, thank you so much for that presentation. I really do appreciate it. You are making a change in your community, and I hope that that change can filtrate throughout the state. Yes, more funding is needed. Now we will go to Ms. Claudia for her presentation.
Y'all, I didn't know that we had the ability to have presentations. And so what I'm going to do instead is kind of just speak to some of the elements that was already shared in the space. And I really appreciated the facilitation that Alina and Mustafa provided to us, because I think it set some level of ground setting for us. And in that, some groundwater, some fresh water that is nourishing for our hearts and souls. And so with that said, y'all, I serve as the Department of Health as the Environmental Health Disparities Map Equity and Social Justice Strategist, which is a very long title to basically say that I support community engagement from where the conversations are happening. And so rather than coming into a space and trying to elicit a kind of a closed-ended conversation, it's really kind of just listening instead to what community members need and making sure we are supporting them where they are, right? The conversations that they are bringing up, the things that matter to them that impact their lives in terms of health risks, social determinants of health, as well as risks in terms of health disparities. And so with that, there was a creation of a tool back in 2017 called the Environmental Health Disparities Map. There was a graduate student at University of Washington who now sits on our Environmental Justice Council for the state of Washington, who was really concerned that those who needed the most support oftentimes were not properly represented in certain areas. And so they created what's called an impact tool, a cumulative impact tool, which is what the EHD map is. And we had team members at the Department of Health that was working with this graduate student. In 2019, the Department of Health adopted that tool so it could be made available to the public to use. And what that tool does is it shows, based on Washington as entire state, looking at census tract information and also content provided to us through community engagement, where persons felt they had the greatest impact or needs from different communities. So not only can you use this tool, for example, to look at different geographic locations of those who are highly impacted, but you can also look at and use this tool to see from minoritized and vulnerable as well as invisibilized communities, what is the impacts to them? In that, there are also layers. So you can look at the tribal layers, you can look at the incarceration, you can look at health zones or lack of thereof. And so for me, in terms of community engagement, one of the things that I really appreciate about our Washington Tracking Network, which is the area I work in, is they shared what the tool was and asked for my input. And I said, my context is very different from those who are being impacted by the social determinants of health, the environmental determinants of health, as well as the health risk determinants and disparities. So we need to go out there and speak to our community members. Many of you are aware of the HEAL Act. The HEAL Act stands for A Healthy Environment for All, that was adopted in 2021 into law. And so that particular law supports community compensation for their feedback. One of the things Alina and Mustafa mentioned was oftentimes we go into these communities and we extract, right? And I think of it, I'm like, when I sat down and I really thought about it, I was like, yes. You ever been in that conversation where a person's like, tell me about yourself? And they tell you nothing about them first. You know, they don't tell you about the cultural values. There's no trust building in that space. And so one of the things we have come to recognize in our section is that, you know, we may not be the best persons to show up in that space. We need to build trust with community members. And oftentimes there are persons who can do that job way better than we can do it. And so making sure that community members who have those experiences are compensated for their time, value, and input, and that we are not gearing the conversation to what we want answers for. Instead, we come in with a very open and outward mindset to listen to what they are sharing in that space. And then if we make any conclusions or assumptions, that we go back to those very community members and ask them again, you know, is this what we heard? Did we get it right? What would you like to change? And in that process too, they are helping and will be helping design what our environmental health disparities map looks like in the future. By law, we have to update the environmental health disparities map every 3 years because it's also partially funded by the CDC, Centers for Disease and Control. And I said to them, you know, we can't wait 3 years, and they all agree. We can't wait 3 years to update community members on whether or not we heard their concerns and what we're able to do about it. And so we're hoping that the new versions of the EHD map as a tool that is quantitative, that has definitions in there, but also the EHD map as it will, in my opinion, needs to evolve into a qualitative tool where community members can see their comments, you know, receive their responses and understand the level of which change can be made. Like, for example, you know, is this something that we can do here at the Washington Tracking Network or the Department of Health? Is this something that requires a greater conversation amongst the other HEAL agencies, for example, the, you know, Commerce or Puget Sound or Ecology? Or is this something that needs to go to ballot, the, you know, legislative hearing or, you know, governor's office? And so for me, that's critically important in our next steps in evolution in making sure that we are doing social justice for all. Because oftentimes and historically, as you know, government has had persons who have very small voices that represent minoritized communities given input, and the context of which that input is given has changed because it's oftentimes we have been removed or just being, how do you say, acclimated by force to different systems that pulls us away from our ways of knowing. It changes the way we reflect back. You know, one of the things, just to bring it back to a personal context here, I grew up partially in Puerto Rico. That's where I learned my Spanish. And when growing up there, you know, on the Isla de Encanto, you see the world from a different way naturally, right? You know, you experience things a different way. And when I came to the US for school, the continental US for school, and when I went home, I realized I had imposed unwillingly, unknowingly, what I had experienced in the US, continental US, and particularly in Spokane, on the community I grew up with, and that's not fair. And so it's really important to us at the Department of Health that we kind of change our so-called mindset, and in that we compensate community members for their voices because they are living in that space in that moment right then and now, in addition to having the lived experiences and the professional experiences. I think also too, recognizing that we need to do more work on ourselves is critical. And so, you know, I often say it is not the EDI person's role to know every single thing. They can't. They can't. And if there's an expectation out there, stop it. That in itself is oppressive, right? And so, but it is important that we have an understanding of what that common goal is from the persons who need it, and that we keep on creating momentum for that. And so I love the fact that at the Department of Health, one of the things that we practice so we can reflect and learn and grow is we intentionally create spaces for those opportunities during the week. And then we have something called Quiet Fridays, or I call them Silent Fridays, right? Which gives us the opportunity not only to catch up on work if you want to, but also to professionally develop ourselves in understanding what we don't know, actively taking into account, like, what are some concerns, communities, some ideas that go in contrast to what we believe to be our foundational understanding that we got from family, friends, and community, and addressing that, right? With ourselves, with books, in small groups of learning. And I think that's important if we're going to come forward to community members and ask them, because many of us know who are online right now, or that we work with. We hear the lofty ideas and then we watch. And to me, it's like a workout class. I'm like, if that teacher in front of that workout class ain't putting in massive amounts of energy in that workout, I take note. I'm like, shade. And I sit back. I'm like, I ain't playing with you like that. And so we are attempting to do that. Is it perfect? No, it's not. But do we have the ability to create greater intention to get to the place where community members deserve us to be? Absolutely. And we're taking an account of what that looks like individually, collectively, and in the processes that we're moving forward to create internally and externally.
Before we go forward, I'm sorry for calling you Claudia. I know your name is Claudine. So I wanted to correct that. So our next, Johnny, do you have slides?
Brandon's going to pull up our website for the ecosystem.
All right, so we'll hear from Johnny next.
All right, yeah,
We're working on it.
oh, okay, cool. Just making sure if I wasn't going to be able to see it or not. So, but anyways, while that's being pulled up, so I'm going to introduce the BIPOC Health Careers ecosystem through our website. And the website is health-ecosystem.org. So the ecosystem was beginning to be founded right before the pandemic. Ian, along with Dr. Ali Thomas, who is spearheading this initiative, was just basically addressing the sheer underrepresentation of BIPOC health leaders in our communities. So the ecosystem aims to increase the number of American Indian, Alaska Native, Black, Latinx, and Pacific Islander health professionals in Washington State. And just a little bit about the ecosystem. So the BIPOC Health Careers ecosystem, we refer to it as the ecosystem, and I hope you all will, if you don't know, like now you know, and you're going to be hearing about the ecosystem because we're doing amazing work, is a backbone organization that mobilizes, coordinates, and facilitates the process of collective impact. So we're a volunteer-driven group of BIPOC leaders and professionals throughout the state dedicated to increasing the number of underrepresented, minoritized health professionals in Washington State. So the ecosystem represents a multi-sector network of BIPOC-led health career programs and partnerships, and it continues to grow. The goal is to develop this network into a service entity that provides organizational support to BIPOC-led healthcare programming across Washington State. So our mission is we connect and cultivate value to those who support American Indian, Alaska Native, Black, Latinx, and Pacific Islander communities through partnerships and advocacy, ultimately leading to increasing the representation in health leadership professions in Washington State. And our vision is that we envision a future in which American Indian, Alaska Native, Black, Latinx, and Pacific Islander health sector professionals lead the elimination of racial, ethnic health inequities harming their communities. And so I won't go through like the entirety of the website. I hope you all jump on our website, but Brandon, if you can click on the join tab, it's a really great opportunity for y'all to join. So as a backbone organization, we're leading convenings to bring together opportunities for engagement with partners. So it can be an ecosystem collaborator, a community partner, ecosystem member. There's many roles and responsibilities on these different levels of the system that we're dealing with. So we're a growing community of BIPOC leaders across the state of Washington. So if you're interested in getting involved with the work of the ecosystem, please join our effort in helping students become the next generation of healthcare leaders in Washington State. And yeah, I won't go too far on, but we have some amazing community partners and board members and staff. It feels like this very grassroots work, the work we're doing. And even though you'll see PhDs and MDs on our board, I think it's still a grassroots movement, because when we think about systems change, it requires people who have gone through the system and basically navigated that whole gauntlet. And those are our grassroots leaders that are coming from our communities that are helping us, break down those barriers, overcome those challenges, dismantle those policies that are keeping these inequities in place from us, from like attaining healthcare leadership careers or positions where we can decide what type of care that we're giving our communities, and be able to empower and engage our communities in designing those health interventions. And yeah, so anyways, I can go on and on, but here's our website. Please check it out and join, because there's really amazing convenings with a lot of partners. So a lot of collaboration efforts are beginning to take off, and conversations happening. So that's it for me.
Well, thank you so much, Johnny, for that information. It is helpful to know that the work is taking place and around the state and around in our communities and things like that. So our last, Ms. Jean-Marie, you do have a presentation, correct? Got you. Muted.
There we go. Just to, before I get into the presentation itself, I just want to bring up a couple of things. And I would say that, first of all, I'm always coming from the perspective of my own lived experience and who I am. My ancestors, understanding the historical experience of my elders and my ancestors, and thinking about the future and creating paths for a healthier and better future for our children, grandchildren, and so forth. I am a grandmother. I have one granddaughter. She's 4. And I mentioned about how important language is earlier. And I don't know our traditional language. I'm Chumash. I don't know our traditional language, but my granddaughter is being raised learning that language. And I see the difference in the sense of just being rooted in these traditions and how important it is. I see the strength in her. And so I love that. And so I just wanted to just share that with you. And then also just a little bit more about, where I show up and how I show up. Certainly show up in a way that has been a really lifetime of doing the work in various different ways. I currently am on the NITI board, formerly known as the Group Health Foundation Board, and I'm very proud of the work that that board has done in creating the concept of very long-term goals, 50-year goals. And so I think about this concept of it's taken us centuries to get to the place that we're at now, knowing that there's been great harm that has been experienced by certain groups of people. It's going to take us more than 2 years to see, the kinds of things change that we want to see. 50-year goals. Billy Frank used to talk about that we need to set goals out 100 years. And it's those systems and structures that don't allow for that. So that's just a thought to think about. And then also the concept of what are we measuring? How do we measure wellness? How do we measure health? And, for a long time, they've been, indicators around disease rates. And so we need to shift our thinking about the, asset-based strengths within our communities and think about, change our mindset towards that rather than measuring the disease. There's so many things that are happening and the potential is very big, I believe, if we start shifting our thinking in that direction. I often think about if we started measuring the health and happiness of our children, our mindset just shifts in a huge way. And I know that that's broad and, all of the systems and structures are not set up to do that. But even having our conversations around what would it take? What would asset-based measures look like if we started shifting our thinking in that direction? I think about the importance of storytelling, and others have talked about sharing stories, how important that is, and how we get to know one another. And again, I think that is a place that we need to make space for that so that we really begin to understand in a deeper way so that we can be good partners and good allies to support the work that's going to support ourselves and other communities. So as we've been talking this morning, these are some of the things that I've been thinking about, but I want to share with you the work of the Washington State Public Health Association, and that's what I was invited here to share with you about. So I want to do that. I also just want to say that I am on the Governor's Health Disparities Council, and I've been on that council for some time. And again, in in that work, I also think about this concept of what we experience in organizations. I think someone talked about it just briefly earlier, is the concept of experiencing microaggressions. And I was in a broader meeting that people were talking, well, microaggressions, is that really our responsibility? Because those are usually like, personal one-on-one kind of things. And so, I really have been thinking a lot about that and about accountability. When we're part of organizations and we're part of groups that work together, we cannot let these things just move on. We need to just create the space, create the environment that people know we're not going to tolerate that. Because people, when you're experiencing something like that, I certainly have many, many times over, it's like getting shut down. Right now, we're in a place where people are speaking up anyway. It hasn't always been that way. You'd get shut down and shut down. And so, we need to create spaces where we say, we're not going to tolerate that. We are accountable for this. We are accountable for the kinds of spaces that we create and what the experience is of the whole, not just ourselves. So I wanted to just say that before getting into this. So the Washington State Public Health Association is an organization that I've been part of since 2018. Actually, I've been a member, but I've been on the board since 2018. And today I'm going to share with you the resolution that we passed in February of 2022 that declared racism as a public health crisis. Next slide, please. And I guess just go back one slide. This picture is actually from the annual conference that took place in October 2023. And you'll see Dr. Shaw, the Secretary of the Department of Health, Chairwoman Charlene Nelson, the oldest chairperson, perhaps she says she thinks it's in the country, of the Showater Bay tribe, myself, and then Kathy Pierre, who is the tribal strategic social justice person that works on behalf of the tribes in the state with the Department of Health. Okay, so the next slide. And then this is the again a picture from that conference. And this just gives you an idea of who is on the board of directors. Currently, the president is Seth Doyle. The president-elect is Julie Peterson, and I'm the immediate past president. I'm not going to go through and go through all of the names, but you can see them and you'll have access to the slides after today, I would imagine. And then the executive director of the association is Megan Moore, and she is the direct contact person. So if you have follow-up, she would be the person to contact, and we'll get that information to you as well. Okay, next slide. So this organization was formed in 1935, very long time ago. But and our focus, and it's grown, continues to grow, has continued to be really innovative in taking on the issues of the current time. It has historically been definitely a predominantly white organization. However, in 2000, they established a core set of values that were around health, equity, diversity, empowerment, integrity, dignity, and knowledge, within the intention to be leading advocacy for public health. And so I think that may have been a turning point for the organization. I'll just say that much. And let's go ahead and move forward to the next slide. And so let's see, I think maybe pull up the points that are there. Yeah, there we go. So in the, I just have to point out that here in this picture, there are a couple of people that I'll mention. Patty Hayes, probably many folks know of Patty Hayes, who has had a long career in the state. And Kamara Jones, who had been the president of the American Public Health Association, but more importantly, from my perspective, I've been following her work for a long time. And if you're not familiar with her work, please look her up. She does, she's created these allegories about racism and equity. She started doing this work in the 2000s. I just saw her back in November, and she's on to digging deeper, and it's even getting better. So follow her work. It's really important. Adrian Dominguez, who was the president of WASPA the year before me, passed on last year. And again, an equity warrior. And he worked for the Urban Indian Health Institute and has had a long career here in this state and California prior to that. Jack Thompson, probably again, some of you know, who again has a long history in healthcare here in this state and with the association, and is emeritus with the University of Washington. David Reyes, the Dean, University of Washington, Dean of Nursing. And so I'll say that much. And then shifting over to diversity, equity, and inclusion, there was an effort and intentional work that was designed around these concepts to develop a diversity, equity, and inclusion initiative. First of all, to begin to educate ourselves. We were at different places as an organization. There were some issues that came forward that in reaching out to communities, which the board did, is wanting to become much more diverse, is they got some feedback from community that said, you need to do more to open your doors, right? So we began to do that work and developed a long-term plan. I became the chair of the DEI committee in, I believe in 2020. Next slide, please. So we began working on the racism as a public health crisis. And I'm just gonna share with you a few things in the preamble. That as an organization, that we honor Indigenous people as the original caretakers of the land in their traditional territories. We honor their ancestors and the generations that have and will follow. We acknowledge the American Indian history of genocide and settler colonialism that attempted to erase Indigenous people with devastating effect on the health and well-being of Indigenous people across the country. We support tribal sovereignty, self-determination, and upholding government-to-government relations. We acknowledge the effect of white supremacy and institutionalized racism on health status, resulting in inequities of higher rates of morbidity and mortality among Black, Indigenous, and people of color. We define white supremacy as the belief that white people are a superior race to the point of being detrimental to other races or ethnic groups. And I'll just emphasize that point right there. This is something that Kamara Jones in her allegories really goes into deeply. I recommend that you look to that. I'm not going to certainly read the whole resolution, but I do want to point out that in the resolution, the American Indian, or excuse me, the WASPA acknowledges that racism is a driving force of the social determinants of health and is a barrier to health equity. So as a result of this resolution, and you can find this on our website, and again, that information is in the slides. Go ahead into the next slide. The resolution is really four-pronged, is that in these four areas: advocacy, education, allyship, and accountability. And in each of the areas, we call out strategies and actions. So it is very action-oriented. It's not just a declaration. It is with intention to make change. And so next slide, please. There we go. So strategies, actionable change. and strategies. I'm just going to pull out a couple of things as we go through each of these areas. I'm going to try and be brief. And so in advocacy, our policies, our policy work, policy advocacy is centered around an equity lens. And some of this you'll see here an image, not very well, but there was legislation that we worked on with communities to support legislation that was a concern because of potentially profiling youth of color. And it took us a long time to do this. The communities a long time that they were right on it, but eventually the Washington State Public Health Association was a catalyst, I would say, also in bringing all of the partners together. Next slide, please. Again, this is much about just seeing that all the way through, that WSPA continuing to be a really strong partner in this work. We also have a legislative day and have done a lot of work in order to make certain that we have good representation in these meetings and in our outreach efforts. Next slide, please. And then education, actionable items, being a conduit for accurate and effective information. This is just from our last conference, and at that conference, climate change was an emphasis for the conference, and we brought different perspectives, Native perspectives from actually what was going on across the country, because climate just doesn't have an impact in our state. And so to bring that knowledge from different lenses to our association membership. The membership is over 600 people. So we've been making certain that there's content that is diverse and also building upon the diversity of our membership. Okay, next slide. I'm going to try and move more quickly. We have a podcast. This is Megan Moore. She's the executive director. And anyway, this is a good way to get involved and hear about what the current topics are that we're working on. Okay, next slide. Especially during the legislative session. Allyship, standing in solidarity with people, raising their voices to eliminate racism. This is a queer Black woman who came to the conference and to talk really about the reproductive justice issues. Again, just, wealth of knowledge. She's a practitioner. Just another example of how we've changed. Next slide, please. Also inviting appropriate and participation with BIPOC communities. Again, just a reflection of that. Another speaker, nationally known speaker in Indigenous communities that came and shared his knowledge with us. Next slide, please. And then strategies and again around some of that allyship. And here again is the chair of the Shawwater Bay tribe and staff people from the Department of Health that have been working on equity issues, particularly around the emergency preparedness work. Next slide, please. Again, this was acknowledging the work of organizations, the Asian Pacific Islander organization that has long been working on tobacco prevention and cessation, the African American Center for Multiculturalism that has also done that same work in the American Indian Health Commission. Next slide, please. Okay, that's it for my slides. I got through them, but thank you. I would just say, please take a look at our website. Consider joining the organization. We are wanting to. We've come from like over 400 to over 600 membership, and we want to continue to build it. Our focus right now is really on bringing those community voices into the mix. Thank you.
Well, thank you so much. Give applause to our presenters. It is an honor to have all of you here and hear from you on what you are doing in your unique communities to address health injustices and inequities. So now we have 20 minutes left before this session is over, and I think we do have some questions in the chat. I will start with one of the questions here. As a Latino and first-generation college graduate working in health equity, do you recommend pursuing higher education, master's, PhD, to effectively contribute to the advancing the work?
I think some people are trying to find the buttons on Zoom, which you always know how to find when you're not facilitating or presenting or a panelist. But the minute you get on like that, you're like, where are these darn buttons, right? Even in the post-pandemic era. And so what I would say is, it's true. What I would say is, there are different ways to create and affect change. And I think we all recognize that. One of the things I will say this from my personal journey, is that you need to start with you. Where are you? Is that something you feel like you need to pursue or not? In westernized countries, and the US is a very much westernized country, they value your input, unfortunately, based on these little alphabets at the end of your name. And I highly disagree with it. And sometimes people have the need to call me Dr. Richardson. I'm like, stop. Dr. Richardson doesn't really exist. All it means is Claudine survived a very majoritarian, white-dominated space in order to be able to at least have a seat at the table sometimes, and then fight for a way so my voice can be heard, which is really the voices of the others and who have been othered, who are not in the room. And so, I have 7 degrees. Do I think that doors open because I have those degrees? No, I think that oftentimes spaces use credentials as a way of eliminating you out of the applicant pool. And so we, as historically minoritized persons at the far end of the racial spectrum, and there is lateral oppression happening in spaces, but we ain't got time for that, to dive into that today, need to be mindful that, that little acronym creates an opportunity, but it is not the opportunity. There are other ways to be involved and have passage into spaces as well. So I just want you to be mindful of that, because one of the things that post-secondary education does not teach you, it does not teach you how to network. It does not teach you how to have passion. It does not teach you how to survive because of it. You usually survive despite of that experience, right? And most post-secondary education schools, particularly, I'm going to name one here at Gonzaga, which is a private institution, as y'all know, in Spokane, Washington. When parents bring their children to that school, they don't necessarily ask, what is the curriculum? Those parents who are helicopter parents ask, what are the networks for my child at this school? They're going there for the networks. They're going there for the connections. They're going there for the internships. And so when you decide to pick whatever post-secondary education opportunities you want to pursue in terms of a master's or PhD, I want you to instead think about, how are you going to make that process best work for you? How are you going to make sure you find the spaces to be in and persons to collaborate with that is going to fuel where you need to be as a person to do the work you want to do rather than the work someone else wants you to do.
Anybody else want to take a chance at that question?
Yeah, I could take a shot. Can you repeat it real quick?
Can you bring up the question? You took it off. Okay.
Yeah, I'll just.
As a Latino
Okay.
graduate student,
what's the benefit of higher education and contributing to that work?
right, do you recommend a master's degree or PhD in order to contribute effectively to the work?
Mhm. Yes and no. I think it certainly is advantageous.
Mhm.
Depending like what level you're working on, because you need that like certification or degree to get within those circles.
Right.
But I think it has to be aligned, because this whole like system that is based off of like extraction and exploitation of people and corruption, like going for something for external validation can be harmful, like to our own health, right? Because we're pursuing something that may not be totally aligned with our passion or like authentically like who we are when we show up as our whole selves, right? And I think that introspection or that reflection is needed, right? And sometimes we don't totally like get it right. So like adaptability and flexibility when pursuing like say our career path is really important, because if it's like, oh, like it's not like this is not what I thought it was going to be, and it's not like totally aligned, but hey, there's something that appeared, or that this experience came about, or this opportunity that is more aligned with like who I am and like what I want to do, and like how I can make change. And it also enables me or empowers me to really stand in my power, right? Those strengths that I have and those skills that I have to contribute how I want to contribute to my communities, So I think it's important to consider those things while pursuing, a master's or a PhD or MD or like whatever graduate program it is. It has to be authentically aligned with like who we are, and becoming aware of like who we are and what we want to do is really important. So
Perfect. Okay. So the next question is, there are limited efforts focused on diversification on health workforce development. What strategies do you have to help diversify the health workforce?
I'll step in for just a second. I don't have a lot to say on it because I'm not working in that field, but I do know that the Department of Health makes a huge effort to center lived experience and people that are being marginalized by the way things are today, and bring them into the decision making. And I think that goes a long way towards starting to bridge that gap.
I'm going to ask if persons can kind of like make the questions more visible or repeat it. Because I know myself, who have an accessibility needs, I'm a little bit struggling to remind myself of the actual like question. So could you repeat it one more time is what I'm trying to say, please?
Absolutely. And I think to just to say something here, as a health policy analyst and a public health specialist as well, I think knowing yourself, I think Johnny said something about this, knowing who you are and where your passion lies has a lot to to inform us on where we end up and the work that we want to do and stuff like that. It's not about, if we don't speak, other people will speak for us and we have to live with it, right? And so when we talk about health workforce and the diversification of such a place, we have to find our place and make our mark. And so the question is, there are limited efforts focused on diversification of health workforce development. What strategies do you have to help diversify the health workforce?
I'm like, I have a whole facilitation on this. Call me. No, just kidding. I'm like here promoting myself. But one of the things I would say is, when I was in post-secondary education, someone thought it was funny, thank you. One of the things I noticed that there was a company reaching out to me and they were offering free mentorship to my students. And I was like, how? These were Fortune 500 companies. And I'm like, how is this possible? How is this free to us at the community and technical college level or the university level? And they explain that certain business, or actually all businesses, get a tax cut for volunteering their employees' time, right? And one of the ways they do that is through mentorship. So Merrill Lynch and Google and Microsoft and Amazon, they all get tax cuts because their employees volunteer. And so, with that, I would say, I didn't know that. How is it widely known? How do we engage in conversations about it? How do we leverage those opportunities? One of the things I think about when we think about professionals coming through and what they pursue, where do we start building that message? One of the other places I grew up is in South America, and I remember doctors coming to the classroom and bankers coming to the classroom, and we go through these exercises on how to be entrepreneurs and how to build things and make things, and I'm like, does that still exist in our curriculum now? Where do students get the counter message that being in a certain field may not be for them? And so how are we creating those intentional pipelines, not just going from left to right, right to left, but coming in all directions to support our students? The other thing I would say too is, who are the faculty members? And I'm hard on faculty. I love faculty, but I'm like, let's be honest, when we think about who the next faculty professional is and we put them on a tenure track, and I do support tenure track, by the way, we are making a decision about cultural value, norms, rituals, and storytelling that will perpetuate for the next 35 years of our students' life. And so education is indeed a pipeline, and who you put in that position is part of what creates either a catalytic reaction or a combustion reaction. You either going to speed up, students being excited about their educational process and goals and how it ties to their cultural values, or you are going to burn them up in the process, emotionally. And that creates trauma. Trauma is a series of events that become either internalized or externalized, and it affects our sense of belonging in places. And as a result of that, we don't feel seen or heard or valued for what we bring culturally. And so I think we need to think about that. I also think we need to think about, for some of these businesses, what it would look like to have not just allyship in this work. Allyship is cute, y'all, but what does it mean to have true mentorship? And by mentorship, I mean you are able to take feedback. Just like you give it, you should be able to take it. And if you can't, you shouldn't be a mentor. And then for those who are struggling with their equity foundation versus being in a lens you can take on and take off, how do you create sponsorship opportunities? Sponsorship is usually created from a person who has institutional or organizational gravitas with positionality, tenure, or expertise that other people value what they say. And so hold on, Johnny, I'm going to pick on you. Johnny may be the head of their agency and they just hired on, Jan Marie, and Jan Marie may not report to Johnny directly, but Johnny can recognize that we have a problem looking at our data qualitative and quantitatively with retention and promotion, and also in our pipeline systems for our healthcare, regardless of what that healthcare system looks like. So they are going to make sure that Jan Marie has the opportunity to work in different sections and offices to get a well-rounded picture, and also to be able to share the ways they show up in cultural practices and innovation to create change.
So I would also like to respond to that in a couple of different ways. Let's see. Also, so first of all, I know Department of Health through a Pathways program is working on workforce issues and creating pathways within local health jurisdictions. And so that's something that I think that, Department of Health could respond to. I don't know. I don't see anyone from that program here today, but maybe that's some information that could get back to you all somehow. And then in terms of a number of things, in terms of WSPA, because I believe I read the question, and they had made mention of a response from the association. So we're doing a couple of things, okay? Well, first I'm going to say, just personally, I've been mentoring someone since she was 17, who is a tribal member. She participated in a youth suicide prevention conference that I was involved in convening. And so from that conference, we've developed that kind of relationship. She has now presented with me in at her own tribe, in a state conference, and 2 national conferences. She is currently in school, and she's also working in their public health clinic at her tribe. She was my shadow at this last conference. And you saw her in the pictures because everywhere I went, she went with me. And towards the end of the event and her time with us, I was handing the mic over to her so that she could address the crowd rather than me. And so I think that just personally, I've been working with a number of youth that came in to do this work with the American Indian Health Commission as youth. They hadn't even gone into higher ed yet, and that they came in as interns, and they have been working with us and with me for over 10 years. So that's my personal commitment to making sure that we're having, our members of our community engaged and developing their own skill set and able to move forward. WSPA, the association, is doing a number of things as well. Is that now WSPA is also, the board members are taking and moving forward with an initiative to have a more formalized mentoring relationship. And so that's going on. We're talking about it now. We also, this is in honoring Adrian Dominguez, who was the previous president of WSPA, who I mentioned earlier, an epidemiologist who had worked with the Urban Indian Health Institute. We have created a scholarship program, and it's in his memory, and it's dedicated to providing, we anticipate substantial support for students that are in the work of public health, in social justice work. And I'm just going to read a quote of Adrian's. Adrian was at a WIC conference, and he just wrote something in one of his notepads, note to himself. And he said, nobody should be trapped by the circumstances they are born into. My story is not unique. I do not want to be the exception. I want to be the rule. And so that is, just wonderful that he left those words with us. We're working right now on that campaign for the scholarship program. We intend to award the scholarship annually. That will be part of our conference announcements. And then lastly, I'll just mention that the association has been part of a collaboration with higher education institutions focused on public health in conversation about what does our healthcare system need 50 years out, that long range vision 50 years out. And we and others have brought in also that thinking about we need to make certain that the understanding of history and culture is really part of that discussion, because that's not part of your standard public health curriculum, or it's thought that those things are in the humanities area, and they're really not part of what would be in a public health program. And so there's been a lot of conversation about that. So anyway, so that I hope that is answers your question. I'm still processing, so if there's more things, I'll put them in the chat.
All right. Thank you so much for this information. We do really appreciate you. We do have a lot of questions in the chat, but our time has come to an end. I just want to seriously thank our panelists. I really, really appreciate the work that you are doing and the information that you are providing us. If there's any information that you feel will be helpful to our students here at the Elson S. Floyd College of Medicine, please send that information on to us, and we'll make sure that the students have access to that information. And now we will take a break from 12 to 1. Our next session will start at 1 o'clock. And any of you, we do have your information. If any of you need, and any attending need CME for this session, please make sure to email us and we'll get that information to you. We do also have a email that will go out to you for an evaluation for this session. And so again, thank you so much to our panelists. If you have one last word of wisdom that you can give us as we end this session, please. I see Dr. Mohammed is raising his hand.
Thank you so much. Yeah, thank you for giving opportunities. I just want to have to just say in 1 minute, I have experiences during COVID. I have two friends that is, one of them have Lyme disease and the other is have sleep apnea and heavy smoker. Both of them get COVID and they almost die. And when we take them to the doctors, to the ER, they neglect them. One of us is Black and there's racism and he has sleep apnea and hypertension and he has smoker heavier and they don't even give him a Plavix. So I told them, the doctor said, I need MRI. I said, you cannot see MRI because there is no changes. He got today the COVID and the test say positive. Can you just prescribe that to him? Then he almost died. If I don't advocate for him and he's Black, he's gonna die. And then I went to the doctor to him next day and he said, sorry for that, they are. So there is racism in the system. There is racism in the hospital. So if we can do training, education for these doctor and provider one, that's going to be helpful. The other one is have Lyme disease and he have a clot in his lung and same things happen and he's white. And because he's obese, nobody wants to see him and neglect him because he's drug addict or whatever. They won't judge him. And that is the two experiences. I saved life for these people. And if I don't advocate and interfere with that, they are now dying. And this is unfair for the human to be died because of the system. So if we can change that, gonna be this helpful. And thank you for giving me an opportunity to tell you this in 1 minute. Thank you so much.
Thank you. All right, well, have a nice afternoon, and hopefully you can join us at 1 o'clock for our next session. Thank you.
Thank you so much.
Mhm.